As indicated, I'm a physician investigator or clinician scientist at NYU Langone. I'm a cardiologist by training and spend the majority of my time I'm doing research into different strategies and ways of understanding risk for patients with either known or suspected cardiovascular disease and understanding the role of air pollution and other environmental exposures for heart disease, cardiovascular risk, and ways to modify this risk at the individual level. So, with all that said, um, there's a lot in the last really 10 to 20 years of understanding the overlaps between cancer and heart disease. And within the field of cardiology, there's its own discipline, really, or sort of subspecialty referred to as cardio-oncology, or managing and understanding the effects of cancer and cancer treatment upon the heart, in ways in which those two act with each other. And one of the things that's gained increasing attention has been the role of cardiovascular risk factors, let's say high blood pressure, diabetes, high cholesterol, kidney disease, other risk factors, and the incidence of and experience with different types of cancers. So one of the things, and this is sort of broadly known, and I'm going to focus my talk kind of on what's the state of the science and investigation and what the data show. Because I think medicine and the research we practice is data-driven and an iterative process of understanding disease and disease burdens. So this is well known, right? Over time, and this is showing basically by uh, race ethnicity groupings of non-Hispanic white, non-Hispanic black, and those of Hispanic ethnicity, the burdens respectively of coronary heart disease, CHD, different, and the numbers here are ICD codes or kind of administrative claim codings, stroke, lung cancer, and breast cancer. And they're major threats to health. And we know that there's a lot of overlap between risk of cardiovascular disease, here abbreviated as CVD, and risk of some malignancies, in this case, breast cancer. So, for instance, having a healthy diet or lower levels of a Western diet, which tends to be less healthy, is associated with lower risks of cardiovascular disease, and with a Western diet, higher levels of a high fat, animal protein driven diet with increased rates of cancer and increased rates of cardiovascular disease. And you can see global alignment with a lot of these factors, right? Increased physical activity decreases your risk of heart disease, also decreases your risk of breast cancer. Some of these things go in opposite directions. The data on light to moderate alcohol intake, obesity, pre and post-menopausal, but the majority of the factors kind of align. And there's been a lot of attention from the American Heart Association over the last few years, rightfully, on understanding more about how cardiovascular disease or heart disease and different forms of malignancies, particularly for the high-risk population of postmenopausal women, how the burdens of cardiovascular disease and different malignancies like breast cancer overlap. And one of the things that we do know, sorry to take a slide back, is that cardiovascular risk factors like high blood pressure, otherwise known as hypertension, diabetes, high cholesterol, a sedentary pattern of physical activity and exercise, obesity, these cardiovascular risk factors also increase your risk of cancer. And this concept of shared risk factors for both brings up this question of really, are some modifiable risk factors cardiac risk factors with their estimated risk of cancers? And what I'm showing you here are two plots, a little bit small and hard to see, but the point being is that when you look at things like obesity, diabetes, or high blood pressure, you can see these risk estimates are all greater than 1, right? Same thing here with tobacco smoking, diet and physical activity, with a whole number of different types of malignancies stratified by sex, by biologic sex. And you can see that across the board, there are different levels of risk function. Clearly, most strongly associated or shown by these risk estimates of tobacco smoking and different lung and oropharyngeal cancers. But across the board, and these risk factors overlap. Um, we know, in fact, that when you aggregate risk factors into risk scores, which is one way that we try and understand and prognosticate risk factors with risk of developing heart disease, that when you put people in categories based on groups of risk factors like sex, age, race, parameters of cholesterol, having high blood pressure or being treated for high blood pressure, smoking or having diabetes, the higher your risk, the more likely you are to also develop cancer. So there's an overlap, a sort of shared or common soil between the risk factors for heart disease in many ways and the risk factors for cancer. And the same thing is true when we sort of operationalize this. And this is slightly outdated data. The American Heart Association has codified this as Life Simple 7. The newest iteration is Life Simple 8 that incorporates sleep into different metrics of cardiovascular well-being. And you can quantify risk for both malignancy and cardiovascular health by your cardiovascular health score. And there is a somewhat linear relationship between your score, your kind of combination of healthful factors or attainment of these healthful factors and risks of both outcomes. And this is just saying this in sort of a longer fashion. So to some extent, it's a bidirectional relationship that cancer, interestingly, as we and others have shown, cancer also appears to increase your risk of heart disease. Um, and this is aggregate data, and this is long-term risk of cardiovascular disease among individuals who survive cancer. Now, part of this is confounded by other characteristics of people that survive cancer. They may be older. They may have other limitations. There are effects of the medications that you've been on or that individuals with cancer may have been on. And you can see that, across for some of these factors, that there's an increase in risk based on type of cancer. This is heart failure or cardiomyopathy or weakening of a heart muscle, venous thromboembolism, which has been a long-standing relationship that's been known about between cancer and blood clots or thromboembolism, and stroke. So there's a relationship that these risks of different manifestations of cardiovascular disease are themselves higher in individuals who have survived malignancy or survived cancer. Um, Now, to drill down a little bit on this, cardiovascular disease increases the risk of breast cancer. Again, this sort of bidirectional nature of this relationship. Now, a couple of years ago, with the lab led by a scientist at NYU named Catherine Moore, she and her research group, of which I was part of for this analysis, showed that when you have a heart attack, otherwise known as a myocardial infarction, it appears in both some animal models and a mouse model and in people when looked in populations of individuals of claims data, that when you have a heart attack or a myocardial infarction, you may actually increase your risk for developing breast cancer or having breast cancer recurrence, which itself was a really kind of interesting and controversial finding. And to kind of go into this in a little bit of detail, this is all data from mice. Sort of why we study mice is because they can give insight into biological mechanisms across different species. And this is showing that if you have a mouse and you did something in a surgical technique so that the mouse has a heart attack, in mice that have accelerated or have a form of a malignancy, you can induce a malignancy in them with cancer cells. compared to mice that have a sham. They don't have a heart attack, but they have a sham surgery. You can see the red line shows an increase in the volume, the growth of the tumor for those mice that had a heart attack. And this is showing you in different fashions over time. Those mice that had a heart attack had a greater growth in the tumor size compared to the normal ones. And the same fashion here, that the mice that had a heart attack also showed a greater progression of disease, of a malignancy, than those mice that did not. So maybe there's evidence here in an animal model, in a mouse model, that it's showing that having a heart attack can potentiate or accelerate some of the effects of a malignancy or the spread of a malignancy. And the same thing was true when we looked at in a cohort of individuals, that if you had breast cancer and you went on to develop and had a heart attack in the 12 years following your diagnosis, those individuals that did had a greater chance of developing progressive malignancy compared to those individuals who did not. And some of the data is a little bit confusing here because while we adjust for those factors associated with risk to try and isolate the individual effects, let's say, of having a heart attack, some of those factors are inextricably linked with the occurrence of that event on both outcomes. So this is suggestive data, but it's by no means definitive. But again, I think reflects back to this bidirectional nature in some ways between, let's say, heart disease risk factors, and malignancy prognosis. So one of the really important things, kind of where the rubber meets the road, so to speak, is thinking about prevention, right? And we in the Center for the Prevention of Cardiovascular Disease at NYU, my colleagues and I have partnered pretty closely with physicians in the oncology group in the Perlmutter Cancer Center in terms of thinking about cardiovascular risk. So managing risk factors, let's say before initiation of therapy, during treatment, after follow-up. So ways that we can think about kind of a holistic approach to managing not only treating breast cancer, which is in and of itself a huge undertaking with a lot of anxiety and time and worry, but thinking in the background, can we also manage the overall risk factors in a comprehensive fashion to sort of improve overall well-being? And we know that these cardiovascular risk factors, so making sure that your blood pressure is well treated, if you have diabetes or trending towards developing diabetes, that you're appropriately addressing that with lifestyle or with medications. So again, sort of taking a holistic approach to thinking about risk factors and cardiovascular risk. This is also to show that there's lots of other stuff going on in cancer treatment, including radiation or different chemotherapy agents that may increase your risk. And this is from a pretty well-known paper over 10 years ago in the New England Journal of Medicine, basically showing that the more radiation that you might receive as part of cancer treatment, the greater the increase in your risk of heart disease. And it's just an important thing that we as physicians and as your care providers think about in terms of care over time for those who are being treated for malignancy or thereafter. Now I'm going to switch gears a little bit and kind of get into, the environment and air pollution, and really environmental factors and health and disease. And this has been a lot of work that really has developed over the last 20 to 30 years as our understanding of the effects of climate change, the environmental impacts of industrialization, and basically anthropogenic sources of exposure that have led to a number of harmful effects. And this is from some work that my colleagues did and published in the New England Journal within the last couple of years, basically showing sort of the ubiquity of sources in the environment that in this case can affect cardiovascular health. basically the sources of industrial air pollution related to both gaseous and particulate emissions, mining and manufacturing and the different chemicals associated with that, the use of manufactured chemicals, the forever chemicals, some of which are listed there, and the ways that you might be exposed to them. And as we're all becoming more familiar with the effects, broadly speaking, of climate change or planetary health, extreme temperatures and wildfires in relationship to their downstream health effects and cardiovascular effects. Now, air pollution is really complex, right? There's lots of things that it's made up of. In general, the most cardiotoxic or cardiovascular, uh, the largest set of adverse effects are those sources of fossil fuel combustion. So we talk about both, coal or industry power regionally, traffic or ships or diesel mobile sources, and homes. There are gaseous components, right, of things that we're not exposed to just one particle or one thing in isolation, but we're really talking about things that are very tiny. And the phrase here is PM 2.5, or particle matter less than 2.5 micrometers in diameter, which is about, between the size of something between a bacteria and a red blood cell. So very small, not visible by the naked eye. But it is something that's so small that it can penetrate far into the lungs. There is evidence that these fine particles can go across the fine layers of your capillaries in your lungs and get into your circulation and result in a whole host of cardiovascular effects in aggregate, which I'll talk about in a little bit more detail. Now, there's lots of organ systems that are affected by air pollution, and these have been shown both in human studies and in animal models, affecting directly of the lungs, the skin, the GU system, the endocrine system. There are direct effects on your nervous system and cardiovascular effects. But as I'll show, these effects in aggregate on the individual level are small. But when you have small effects that affect millions of people, that can lead to very notable health effects for populations. So this is something that we and others have worked on, and this is kind of a classic example of sick individuals and sick populations. So but it's kind of an important concept. It's broadly referred to as the prevention paradox, that if you have a small benefit on an individual level, in this case, let's say you reduce your blood pressure by 2 to 3 millimeters of mercury by limiting your salt intake over time. As an individual, that's not a huge difference, right? You're not going to stop taking your high blood pressure medicines because your systolic blood pressure is 3 or 4 millimeters of mercury lower. But as a population level, when you shift that curve, that bell distribution, that curve of risk for a population, you can achieve very significant reductions in stroke, coronary heart disease, and in fact, your risk of dying by, let's say, making these modest changes. And the same thing that's true with using, let's say, salt reduction, we think is also achievable potentially by using indoor air cleaners. And these are, things, HEPA air cleaners that we all became probably more familiar with than we wanted to be in the pandemic, and can improve indoor air quality. We and others have generated data to show that these portable air cleaners, by improving indoor air quality and lowering indoor levels of particulate matter, can lower blood pressure by about 3 to 5 millimeters of mercury. And we're currently testing this in the largest NIH-funded clinical trial in individuals with stable high blood pressure that are living in public housing. The details for that I can go into in a little bit more detail if interested. And this is sort of summarizing this in a combined fashion, but PACs are portable air cleaners, but the idea being that if we can improve indoor indoor air quality, the biggest determinant of which is outdoor air quality, can we lower blood pressure and improve health outcomes? So there are some strategies, right, that we know do this to different extents. Um, Obviously, the biggest intervention are those that are done on a policy or societal level. Um, I will leave it at those being increasingly difficult to achieve. There are individual strategies that you can take in terms of using portable air cleaners, driving and using the cars' air filters. A lot of the newer cars have HEPA filters, particularly if you're in high traffic areas. Um, Different buildings now can use building-wide interventions. So there are ways that you can modify that individual risk. I'm not really going to talk about strategies, let's say, for targeted avoidance of wildfire exposure, which is in and of itself a whole other set of topics. But there are individual strategies that you can have. We are studying using these air filters overnight in your bedroom, which we have shown that in small studies, and we're testing this now in a larger population, can lower your blood pressure by 3 to 4 millimeters of mercury over a clinically meaningful timeline. And we're testing this to see if this is a sustainable effect over, about 6 months. But this is something we are investigating, and as a potential, shifting the paradigm a little bit from air pollution and environmental exposure as being only a societal concern to potentially being a modifiable risk factor for a number of health outcomes. This is work by, she's now a resident, a medical resident at Cornell, where, she did a meta-analysis, combined all the data of studies to date, and you can analyze it sort of in a combination factor, showing that in aggregate of over 600 people across these studies, air pollution, reducing indoor air quality or improving indoor air quality, lowered blood pressure. Other work by my group, she's now a junior faculty at a physician investigator at NYU, showed that you can also use these air filters and reduce different markers of inflammation in the blood, showing that air pollution or poor air quality, as with other environmental exposures, really has systemic effects, and maybe we can modify those effects in aggregate. And this is just showing you, as summary data overall favoring filtration. These are studies that were clinical trials, so you have a active intervention and a sham or a placebo intervention. And I won't belabor that because again, that could be a talk in and of itself. So this is the study we're doing. Just a little plug for our trial. It's called Air Pressure NYC, reducing air pollution to lower blood pressure among NYC public housing residents. We're doing this in public housing because there's a disproportionate burden of both high blood pressure and levels of air pollution. Environmental factors are not distributed equitably. And this is the trial that we are currently running. We are we're coming at the end of year 2, and so far so good. And this is sort of our primary and secondary outcome of blood pressure over time, which is the study that we're running. So going a little bit forward, of air pollution, cardiovascular risk, and cancer survivorship, or air pollution and cardio-oncology. So as you may have sort of anticipated, there's a lot of shared risk, right? So we know that, as we talked about initially, when we look on this left-hand part of this figure, and this is some work that my colleagues at a couple different institutions laid out for the American College of Cardiology, this sort of subspecialty journal focusing on cardio-oncology. There are shared risk factors, shared modifiable risk factors that influence both risk of cancer and risk of heart disease, those things that we've talked about, being overweight or obese, having diabetes, high blood pressure, hyperlipidemia. I've sort of alluded to it, but socioeconomic status is a variable. Unmodifiable ones, you can't change your biological sex, you can't change your race, and you can't change your genetic hand that you're dealt, but the data would suggest that you can modify the risk of your genetic hand, so to speak, in a way that your genes are not only your fate, particularly for heart disease. And there's evidence both for, sort of shared pathways, both in a short duration and longer duration related to inflammation and oxidative stress, immune responses. And this is showing you, these effects, right? The environmental exposures here. So the fine particles getting into the bloodstream, primary and secondary air pollutants that maybe we can do something about on an individual level as we work towards more broader population and societal changes. Um, so this is a complicated slide, but showing you that, air pollution is made up of lots of stuff, right? So there's all these things in air pollution, both particulate matters, gaseous pollutants, semi-volatile liquids. They all kind of combine. Different things happen in the environment. Again, these are exposures that are complex in and of themselves. And we focus on one small element, one small particle for the sake of discussion and clarifying concepts. But there are many things involved and many things that you're exposed to that have health effects. And this is showing you sort of a distribution across a number of counties in the United States, of where, these different makeups of particles. What you're exposed to with wildfire exposure is different than traffic exposure on a hot summer day in Los Angeles. So there is some variability in terms of exposure and differences in health effects. Um, but I would tell you that, there's again this sort of common soil of heart disease and malignancy or cancer. This is showing you, data, it's now more than 5 years old, but these trends have largely held true that the burden of both attributable cardiovascular disease and attributable, let's say, mortality or succumbing to cancer death, lung cancer, is felt uh, broadly speaking in the global south, right? In the sort of rapidly developing and industrial communities. And much of both North America and parts of Western Europe, because of regulatory frameworks and changes that have been made in our patterns of use and industrialization, have reduced both of these burdens in tandem. But you can see that there's a lot of overlap, between the areas in dark blue here and the areas of dark orange, both in sort of areas of Eastern Europe, and parts of East Asia and Southeast Asia. Um, this is showing you some correlations, but there again, there's different magnitudes of risk. One thing that I think is interesting, and I won't really belabor the correlation between these, is that you can just see that the numbers here, the scales are very different. So the burden of mortality attributable to fine particulate matter due to lung cancer is much smaller than the burden related to fine particulate effects and cardiovascular risk. And there's a little bit of a misconception. A lot of people think that air pollution's biggest risk is affecting the lungs. As a cardiologist, I like to think that the lungs only exist really to help the heart function. I'm not just being glib, but the burden of morbidity and mortality related to environmental exposures and lung and air pollution in particular is largely due to cardiovascular disease, not due to things like asthma or lung disease, which may exacerbate symptoms and are an important driver of other related quality of life and morbidity. But the cardiovascular burden from these exposures is quite substantial worldwide. So, I think there are a couple of things to think about. Like, what do we do about this? We can't live in a bubble. We all exist in the worlds we live in. And I think it's helpful to think about both personal level and societal or government level strategies. And you can't have one without the other, right? So maybe that's a lesson for today in general, but personal level strategies, um, I think it's important. We don't really know how best to operationalize conveying risk of environmental exposures and what to do with that information. Yes, there are air quality indices that you will hear about. Um, um, it's useful to think about your individual risk when thinking about what to do. So by susceptible individuals, if you've had, let's say, heart disease, you've had a heart attack, you've had procedures on your heart, if the air quality is very bad, let's say in the short term, it's a wildfire day in New York due to Canadian wildfires, or due to some of the fires that Los Angeles recently experienced. These acute exposures, doing different things to try and minimize your exposure is certainly recommended, right? Chronically, I think in your exposures low, and I'll show you a little bit of where exposures to air pollution are for the US writ large. Um, you can think about other strategies like lifestyle changes, HEPA filters, as I mentioned, to reduce indoor air quality exposure, or to improve indoor air quality. Um, but for instance, I frequently get the question of like, well, if it's a bad air quality day, should I avoid exercise or should I avoid exercising outside? And as a preventive cardiologist, I am loath to ever recommend to anyone that they decrease their level of physical activity or exercise. But I think there are ways that you can modify that risk. So if you're a person who likes to exercise outdoors and it's a hot day in the summer, and the air pollution, the air quality indices are very high, don't walk along the FDR that day. That might be a day where you can do some indoor activity if possible. But that again is something that you need to take into account in terms of your baseline risk, that you have that discussion with your physicians and your care team. Now, we're only going to get there for meaningful risk reductions when we think socially and on a global policy level, uh, for which that's anathema. But there are things that we can obviously do to make meaningful changes to broader exposure patterns in the US and worldwide. Um, so, again, my colleagues sort of put forth this idea of air pollution monitoring and maybe cardiovascular and cancer risk assessment in the domain of cardio-oncology. I think it's important to think about, if you take away one thing from this talk, to maybe talk to your care team about your cardiovascular risks and whether or not it's worth thinking in more depth about how to lower your risk for any relevant cardiovascular risk or cardiovascular disease or process. And then in that context, it's not unreasonable to think about indoor air quality in general, and then what to do here. This is maybe thinking about different screening protocols, but we don't really have evidence for that for heart disease in the absence of symptoms. I would focus on risk-based monitoring, and air pollution may contribute to a measure of environmental risk or lifestyle risk that maybe we can do something about on the individual level. So I just want to close with, a refresher of where we've been and where we are now, as a result of things like the Clean Air Act. So this is Richard Nixon, right? December 31st, 1970, signing the Clean Air Act into law, which drove the use of unleaded gasoline, driven in part by industry and the development of catalytic converters, which could not burn leaded gasoline. And as a result, this is showing you air quality in Detroit over the last, I guess, 1970, now almost 50 years, right? This is where we were. We were at 200 micrograms per meter cubed. Now, the current levels of fine particulate exposure, let's say in the when the Canadian wildfires a couple of years ago in New York, were over 300 to 350 micrograms per meter cubed. So this was average yearly measures in Detroit in the 1970s. A really marked drop off to the 80s. These are standards. These are national air quality standards. Initially, 30 years ago, we're at 75 micrograms per meter cubed. In the 90s, the standard was dropped to 15. 2012, the standard was dropped to 12 micrograms per meter cubed. The EPA had lowered the standards even below 10 because there's really no safe threshold for things like air pollution. There's no safe level of PM 2.5 where there are not measurable physiologic effects. It's just a question of resources and tolerance for how we're going to legislate some of these changes. But this is where the effects of policy can be felt. And I can, if you were to draw and overlay with this, there's been a concomitant decrease in cardiovascular disease and a decrease in cancer incidence over the United States population during these time periods. There's multifactorial reasons that those things have gone together, but one does influence the other. So I just want to sort of close with that as a last note. And PM 2.5 standard now is 9 micrograms per meter cubed, whereas back, 35, 40, almost 50, more than 50 years ago, it was 50 micrograms per meters cubed. So I'm happy to spend a few minutes and go through a few questions. This is who I am, and it was a pleasure sort of running through some of this information tonight. It's a good question. I mean, I'd say that, you know, we know that air pollution is higher levels of air pollution are associated with increased levels of a number of cardiovascular risk factors, high blood pressure, or increases in blood pressure, effects on blood glucose. Um, so the question is sort of that risk relationship is pretty well defined. Um, the question is sort of what we do about it on both an individual and policy level to mitigate that risk. And as I pointed out, there are some individual strategies and potentially that would tie into policy level interventions. So that's a very good question. I showed one slide from the New England Journal showing that the dose or the amount of radiation that you've received from cancer for cancer treatment is associated with cardiovascular risk, meaning the risks of developing cardiovascular disease and cardiovascular risk factors. Chemotherapy is the same thing. Most people are aware of the chemotherapeutic effects on the heart and monitoring cardiac function with the use of different chemotherapy agents. But we know there are effects of chemotherapy on cardiovascular risk factors itself. So 2 comments about that. Wildfire is a increasingly relevant exposure. We know that the very high levels of wildfire or wildland smoke are associated with detrimental health impacts. It appears that the physiologic effects are different from burning organic matter than fossil fuel combustion. Secondhand smoke is a very potent risk factor. It's why one of the more obvious reasons why different cities around the world, including New York, have gotten rid of indoor smoking because secondhand smoke exposure is such a potent risk factor for both respiratory and cardiovascular endpoints. No, CPAP machines do not have HEPA filters. CPAP is continuous positive airway pressure that has salutary effects on your oropharynx for individuals with sleep apnea or sleep disordered breathing. There are machines, I think, that can include HEPA filters, but I haven't really looked into those much. If you wear an N95 mask and you wear it right, The short answer is yes. If you just wear it over your mouth, the answer is obviously no. The problem is with heart disease is that it's stochastic, right? You can have a lot of risk factors, and probabilistically, you're still not going to develop, thankfully, let's say cardiovascular disease or to have a heart attack or cardiac event during a wildfire smoke exposure. Um, we know that respiratory presentations tend to go up during levels of very high or very poor air quality exposure. Cardiac events also peak during those times, but they also peak at other times that are not related to air pollution exposure, like Super Bowl events or World Cup victories or losses. People get excited and do dumb things, and cardiac events happen at the same time. So there is certainly an awareness. It's difficult to disaster prepare for every eventuality. I think there is some awareness that this is a risk factor. It becomes challenging for physicians to think about because it typically is not within the purview of something that can be modified. Um, I don't have many thoughts on duct cleaning. There's, there are building HVAC systems that can focus with greater degrees of particle filtration versus others. There are building engineers that do this work. I am not intimately familiar with it. I focus more on the individual patient level risk factors or patient level factors, but there is a good body of evidence about HVAC upgrades and certainly maintenance to maintain, let's say, existing HEPA filters. So that's a very interesting question. The short answer is no. Um, there's no evidence to support. Part of the problem is that there's tremendous heterogeneity in the test performance. So what lab X measures may be different from what lab Y measures. Now, that's one of the things that government standards are good for, like the CDC and the National Health and Nutrition Examination Survey, that rigorously, in a gold standard fashion, measure population level exposures or have measured. But in general, the consumer level blood or urine quantification assays are not that reliable or reproducible. And we don't have great evidence outside of, let's say, measuring lead levels in children, which are done in standardized labs, that it's going to change health outcomes meaningfully for adults. But we have looked at this. We finished a large clinical trial using chelation therapy as a follow-up study to largely lower the levels of cations in the blood of lead and cadmium. And despite lowering the levels in patients with diabetes who had had a heart attack, it did not reduce the risk of recurrent cardiovascular events. Those results were published this last year in JAMA, the Journal of the American Medical Association. The first author is Lamas et al.